Hello guys, this is Dr. Asif. Today I'm going to continue my previous topics, that is pre-operative preparations. Now I'm going to start the post-operative management in the video channel, that is MRCS Study with me. So let's start the post-operative care, the radar notes. So first, there are some topics which is very important according to the NICE guidelines. Here the acute dystonic reactions, then renal failure, brain death related questions. So ARDS, management of pain, neuropathic pains, circulatory supports of critically ill patients, cryoprecipitates, massive hemorrhage, and the hypovolemia in the surgical patients. And there's some NICE guideline related nutritional screening programs, so refeeding syndrome and the nutritional prescriptions and so on, other embolism, surgical complications and so on, surgical site infection, which is very important. Here you can see cartoons that is MRSA, a very strong resistant bacteria. So we have created a monster, that means overuse of antibiotics sometimes make a normal bacteria become more ferocious one, which antibiotic resistant bacteria. So he is going to kill his own normal flora. That is in the cartoons. First, the acute dystonic reactions. So here it is anti-dopaminergic drugs such as antipsychotic may be result in extrapyramidal side effects, and this may range from the mild Parkinsonian symptoms such as resting tremor and the bradykinesia, though to acute dystonic reactions which are characterized by abnormal and involuntary facial and bodily movements, such as spasmodic torticollis, oculogyric crisis, and the oromandibular dystonia. Here, first things first, oculogyric crisis, very important. Sometimes I have seen questions about the oculogyric crisis, where there is evidence of extrapyramidal side effect of due to overuse of TCA, that is tricyclic antidepressant, which act as antipsychotics, and they present as a oculogyric crisis. In the chronic cases are generally only encountered in psychiatric units. In the surgical practice, the administration of the anti-dopaminergic drugs metoclopramide may be sufficient to precipitate. So here the metoclopramide is the culprit of happening the oculogyric crisis. So overuse of metoclopramide sometimes the culprit, but we should use it cautiously. So for the treatment purpose, benzhexol, procyclidine are the two drugs which may be used. Now the acute renal failure. So here the final pathway is a tubular cell death. In the renal medulla is a relatively hypoxic environment, making it susceptible to renal tubular hypoxia. So renal medulla is a relatively hypoxic environment, making it susceptible to renal tubular hypoxia. So renovascular autoregulation maintains the renal blood flow, causes the range of arterial pressure. So it is all we know about what happens during the acute renal failure. So there is a decrease of blood pressure of the renal tubular cells following renal tubular hypoxia occurs, followed by the ischemia and the tubular necrosis. So estimates of GFR best indicates the level of renin function. So and the eGFR calculations such as the Cockcroft and the Gault equations are the less reliable population of the high GFR. So nephrotoxic stimuli such as aminoglycosides, radiological contrast media induced apoptosis. Here another thing is myoglobinuria, and the hemolysis is a result of necrosis, which is so common in our country nowadays. Overlap exists. The pro-inflammatory cytokines play an important role in the potentiating the ongoing damage. And the post-operative renal failure is more likely to occur in the patients who are elderly, have peripheral vascular disease and high BMI, have COPD, receive vasopressors, are on the nephrotoxic medications, or undergo emergency surgery. So avoiding hypotension will reduce the risk of renal tubular damage. You must remember here. So we have to make the renal perfusion perfect always, because if the circulation is decreased, in that case renal system is irreversible to repair, like a nerve cell. That's why hypertension must not occur to reduce the renal nephron sparing situations. So there is no evidence of that administered CE without dopamine reduce the incidence of postoperative renal failure. So dopamine is not always helpful, or administered CE inhibitors will not actually prevent the renal failure. Now the brain death. Brain death is a question which comes to the MS exam, that is entry exam sometimes, or sometimes in exit exam too. So there are some criteria of brain death. How can you know that the patient is already dead from very inside? That there is some criteria, that is deep coma, known etiology, reversible causes of excluded, and no sedations, and normal electrolytes. Okay. And testing the blood brain death, that is fixes pupils which do not respond to sharp charges in the intensity of the incidence of light. No corneal reflexes, absent oculovestibular reflexes, no eye movement following the slow injection of at least 50 ml of ice cold water into each ear in turn. Okay, so absent oculovestibular reflexes and no corneal reflex, and people become fixed, and this that do not respond to sharp changes in the intensity of the light. No response to supraorbital pressure, to no coffee influx, no observed respiratory fog, and the elevation of partial partial pressure of carbon dioxide to at least 6 kilopascal. Now the adequate oxygenation is ensured by the pre-oxygenations and the diffusion oxygenation during the disconnections. The test should be undertaken by the two appropriately experienced doctor and you must take two separate opinion of two doctors, because it has some connected with medical legal purpose, because if you fail to give death certificate, sometimes you can be fall on a trap which is a trap of law. So this must be checked by two separate occasions by the doctors. Now the adult respiratory distress syndrome, one of the important topic which has been discussed in the pathology, but also it is been used in surgical practice. So it is an acute condition by bilateral pulmonary infiltrates and serves hypoxemia, an absence of evidence of cardiopulmonary edema. Clinically, a pulmonary capillary wedge pressure of less than 18 millimeter of mercury. It is subdivided into two stages. Okay, early stages consist of an exudative phase of injury with acid edema. The latter stage is one of the repair, and the consists of fibroproliferative changes. Subsequent scarring may result in poor lung functions. So what are the causes of ARDS? How can you know that? That is a sepsis, direct lung injury, then trauma, then acute pancreatitis. So adult respiratory distress syndrome has some specific causes, because we encounter sepsis, which is very obvious or come usually in a hospital practice. And the direct lung injury due to trauma due to in mismatched blood transfusion, that is TRALI, transfusion related acute lung injury, which also a condition of ARDS. And acute pancreatitis because it causes pulmonary, both bilateral pulmonary effusions. And the long bone fracture, the multiple fractures through the fat embolism, which is so common in orthopedic practice because they usually reconstruct the long bones and causes a chance of thromboembolism or fat embolism. In the head injury causes sympathetic nervous stimulations which lead to an acute pulmonary hypertension. So head injury causes sympathetic overdrive. In the clinical features, acute dyspnea and the hypoxemia occurs days after event. Then multi-organ damage after later on the raising ventilatory pressure, and the management is acute dyspnea, that is breathlessness. And the management including the treat and analyzing the causes. First things, antibiotics, the negative fluid balance, that is diuretics use, and the recruitment maneuvers such as prone ventilations, use of positive and expiratory pressure, that is IPPV, that is intermediate positive pressure ventilations. One of the very important techniques of reversing hypoxemia or ischemic conditions by giving adequate oxygenation to the tissue level, that is intermediate positive pressure ventilations, which also a treatment modality of the ARDS. The mechanical ventilation strategy using low tidal volume and conventional tidal volumes may cause a lung injury. Now management of pain. So pain management also been managed by not only surgeons but also the medicine specialists as well as anesthesiologists as well. So here, according to the WHO organization, that is anesthetic analgesic ladder. First, we can use paracetamol, non-steroidal antibiotic, anti-inflammatory drugs as NSAIDs if the pain control is not achieved. Then second part is weak opioid like codeine and deoxymorphine, dextropropoxifen. Oh, very bad. So just focus here. It's codeine, okay, which is weak opioid, which can be used as a second line drug because it has some appropriate agent to control and minimize the side effects. And the final drug of the ladder is to introduce strong opioid like morphine. Analgesics from peripherally acting drugs may be addictive to that from centrally acting opioid, and thus the two are given together. Now the World Federation of Anesthesiologists, the WFSA, has their own analgesics ladder. They said for the management of the acute pain, initially the pain can be exacerbated by severe and may need controlling with strong analgesics. So firstly, they used to go in the strong analgesics in combination with local anesthetic blocks and the peripherally acting drugs. The second drug on the postoperative pain ladder is to restore the use of the oral route to deliver the analgesia. Strong opioid may no longer be required, and adequate analgesia can be obtained by using combinations by peripherally acting agents of weak opioids. So they used to say not to use morphine frequently, but they believe on combination therapy because along with small opioid, sometimes they use to hair. Strong opioids may no longer be required, and the adequate analgesia can be obtained by using combinations of peripherally acting agents, that is using oral route along with some morphine, though it is not so ideal because there is a chance of vomiting, there is a chance of many other things. Okay, the final step is when the pain can be controlled by peripherally acting agents alone. Now the local anesthetics. So filtration of wound with long acting local Anesthetics such as bupivacaine. It's a long-acting local anesthetics. Okay. So analgesics for several hours if by dissection of this Staphylococcus aureus infection, that is boil, abscess, cellulitis. We have to make incisions or the excision of the lipomyositis cyst. Sometimes we have to excise it from the local area, so we need analgesia for several hours. And the further pain relief can be obtained by the repeat injections by infusion via thin catheters, that is epidural catheters. And blockage of plexus or peripheral nerves will provide selective analgesia in those parts of the body supplied by the plexus or nerves. Can either be used to provide anesthesia for the surgery or specifically for post-operative pain relief, especially useful where a sympathetic block is needed to improve post-operative blood supply, where the central blockade usage of spinal epidural blockade is contraindicated. There is another treatment protocol of pain that is the blocking of the sympathetic channels, but the problem is there is maybe they will suffer their spinal cord block related problems. Now the spinal anesthesia provides excellent analgesia for surgery in the lower half of the body. Pain relief can last many hours after completion of operations if long-standing acting drugs and vasoconstrictors are used. Side effects: spinal anesthesia, hypotension, sensory motor neuron, nausea, urinary retentions. Very important today in the exam. I have encountered these questions. What are the side effects? That is hypotension, sensory motor nerve block, and the nausea and urinary retentions. And the epidural surgery and indwelling epidural catheter is inserted. This can be used to provide a continuous infection anesthesia. It can be proved excellent analgesia. Yet there are still preferred option for following major open surgery procedure and help to prevent postoperative respiratory complaint resulting from pain. So here the patient control anesthesia, that is very popular nowadays. On intravenous anesthesia, titrate the dose and there one point relief using a small microprocessor and controlled pump. Morphine is the most popular drug here to use. Now the strong opioid severe pain arising for the deep and visceral structure requires strong analgesics. And morphine, short half-life and poor bioavailability, metabolized in the liver and the clearance is reduced in the patients with liver disease. And early the debilitated side effects include the nausea, vomiting, constipation and respiratory depressions. Tolerance may occur at the repeated dose. Now the pethidine, that is synthetic opioid which is structured different from morphine but similar actions, 10% potency of morphine. So pethidine is usually formed in the laboratory with the similar effect of morphine, but potency is less than the morphine. So short half-life is similar availability of pethidine and morphine. Short duration of action may need to be given hourly. Pethidine has a toxic metabolite which is norpethidine, which is cleared by the kidney, by which accumulates in the renal failure and following frequent prolonged dose may lead to muscle twitching and convulsion. Here the other opioids, that is codeine, which is markedly less active than morphine, has a predictable effect and and when eventually its effect is a mild to moderate pain. And if one of the important things is that is non-opioid analgesia, mild to moderate pain, the inhibit prostaglandin synthesis analgesic and antipyretic properties but little or anti-inflammatory effect. This is well absorbed. It is well absorbed orally and the metabolized almost entirely of the liver. And the analgesics antipyretic properties little low inflammatory effect. And now the it causes hepatotoxicity in the overdose of the overriding normal metabolic pathway and the femoral toxic metabolites. NSAIDs, that is analgesia and anti-inflammatory drug. Inhibition of the prostaglandin synthesis and enzyme cyclohexane, which catalyze the conversion of the attached to prostaglandin, are the chief medical inflammations. All the NSAID work in the same way, as thus there is no point of giving more than one at a time. NSAID and the general useful for superficial pain arising from skin, buccal mucous, joint surface, and the bone. Relative contraindications: history of peptic ulcer, gastrointestinal bleeding, and bleeding diathesis. Here we can use limited amount of NSAIDs here, because there is a chance of skin, buccal mucous, and joint surfaces, and bleeding from the bones. And now the neuropathic pain can be defined as a pain which is arising from every following damage or disruption of the nervous system. It is often difficult to treat poorly standardized analgesia. So there are some diabetic neuropathy, post-herpetic neuralgia, trigeminal neuralgia, post-prolapse intervertebral disc. So first things first, according to the NICE guideline, oral amitriptyline or pregabalin, which is very important. If satisfactory pain reduces to obtain with amitriptyline but the person cannot tolerate the adverse effect, then consider oral imipramine or nortriptyline as an alternative. Second line, first line treatment was amitriptyline, which switched to or become the pregabalin if the first was in pregabalin, which to our combined with amitriptyline. Other options: the pain management clinic tramadol, and the opioid lidocaine or local pain if patient are able to take oral medications. Please note that some specific conditions, for example, carbamazepine used for first line of the trigeminal neuralgia, and duloxetine for diabetic neuropathy. So in my mother's a Indian doctor prescribed the duloxetine for a diabetic neuropathy, but he was laid on the back for all day long due to the effect of duloxetine. It is not so good drug, but we have prescribed it for better outcome for a short duration of actions. Okay, so that is all about today's presentations. There are a second part of post-operative care, because it is very enlarged. I think I should go for another things for preparing the post-operative, the later part, that is circulatory support for critically ill. So for watching the video, please like and subscribe my channels and stay with me. Thank you very much.